Thank you very much. Hi, my name is Rick Shepler from the Center for Innovative Practices, and I'm joined here with Michael Fox and Dr. Christopher Balanchi. And we are doing a regular series on co-occurring disorders of adolescence, and specifically developmental trauma, substance use disorders, and related mental health disorders. Today will be anxiety, is our mental health disorder of focus. And we're thrilled to have y'all, and I'm going to let Mike take over our PowerPoint, and you'll hear from all of us throughout.
Thanks, Rick. Good morning, everybody. I think, everybody listening, it is morning. I apologize if you are on the West Coast side of things. We tried to get this bumped later. We were being very geographically centric when we first thought 11 a.m. Eastern time, thinking, oh, that's right before lunch, but it's only right before lunch for about a quarter of us. But by the time we considered that, it was too late to move it, so we're going to try to do this later in the day in upcoming webinars that we have in this same series. So there's good news in the presentation today in that I will control the slides, but luckily we have Rick Shepler and Christopher Balanchi who are going to be adding comments to my slide control. So we are going to follow a similar pattern that we did in the first presentation in this series. And the last time in December, in this same learning community series, we covered depressive disorders, drug and alcohol use, and trauma, both from a singular traumatic, a PTSD standpoint, but also a developmental trauma standpoint. The intersections of these areas and thinking about them in an integrated fashion with all of the overlap, and there is a lot of overlap when it comes to adolescence. And so all of that is wrapped within the perspective of considering the very specialized developmental period of adolescence. So if you joined us for that first one in December, it follows that same pattern. A few of the slides are even the same from the first time around, but this time going through, we're making the change and adding the consideration of anxiety instead of depression. So, certainly there's kind of similar symptoms, different sides of the same coin kind of thing when it comes to adolescence with depression and anxiety, but there is enough of a difference that the perspectives, even if some of the slides are the same, we're going to have some different perspectives. So, starting our consideration, thinking about the developmental aspects of adolescence. Adolescence is a period of development that is unique to itself, and I think so often, we run into the danger even when we know better. But I guess really I'm speaking for myself, and I am assuming that other people fall into the same traps that I do, that when you're working with an adolescent, they hold a conversation like an adult, and we have adult expectations for them, but we also expect them to respond like they're still children, and neither one of these things are true. They are neither little adults nor big children. They are very much teenagers. They are adolescents. And so the way they experience things and the way they conceptualize things, and certainly the way they are wired, is very different. The slide mentions that it is an extremely active period of brain development, growth of a large number of synapses and increased sensitivity to dopamine, which certainly ties into both trauma and drug and alcohol use, followed by a later pruning of connections towards a more efficient organization. So what this means is they have a whole lot more neural connections available to them than are needed as they move forward in a more efficient way of considering information, and that's what's going on. The interesting thing about adolescence is that it's considered to be the second most active period of brain development after infancy. As I would think about it, logically it would seem that brain development would be at its highest level during infancy, and then in a stepwise fashion, it would decrease into adulthood through toddlerhood and early school age, et cetera. But, nothing can touch infancy in terms of the activity of the brain development. But the second most active period is during adolescence. There's so much going on. So what does that mean in terms of the way they process information and certainly the way they appear behaviorally? And if you have ever been around a teenager, and I'm assuming all of you have at some point, teenagers are a little less predictable than adults. And they're even a little bit less predictable than children, just because of the way things are going on brain development-wise. And so when we think about how is that impacted by drug and alcohol use, how is that impacted by complex developmental trauma and singularly traumatic events, how is that impacted by those things, and what's the presentation there? And then what happens if you have an overlap of some sort of mental health disorder? And today we're considering anxiety with that. And if you think about what it is to be a teenager, being a teenager is a pretty anxious period of life anyway. So this represents for teenagers a lot of areas of risk, but it's also a time of great adaptability. So that's good news for those of us who work directly with teenagers, work in programming for teenagers, in terms of thinking about their adaptability or their plasticity, their neuroplasticity. There is a lot of room for change that we can help them and help through their families make changes that are going to have lifelong impacts. So cognitively, in terms of the way they process information, I think about it, no subtle pun intended with that, but I think about it in terms of the way Piaget organized cognitive developmental perspectives, in terms of the way they're moving from black and white thinking into the more formalized adult thinking. But, it doesn't happen overnight. It's not that magical line at 12 years of age when they go from, concrete operations into formal operations. That period is spread across at least a decade, if not a decade and a half. So it's not an overnight process. It takes a long time. And part of that developmental period that includes the influences from the things that we're talking about today. So developmentally with teenagers, these things are on this is what you should expect with a teenager. Increased, or not increased, but a higher level of impulsivity than you would see with adults. More emotional reactivity, and that's perfectly normal. A greater degree of risk-taking, and it's interesting that that's also balanced by a greater degree of inhibitory thinking, because both sides of that coin are turned on with all of these neural connections more than they're ever going to be any other period of life. So not just greater degree of risk-taking, but also a greater degree of inhibitory thinking. But when those two come into direct conflict, we know for most teenagers which one is going to win out, the inhibitory thinking or the risk-taking thinking. And typically with a teenager, it's going to be the riskier side of things. So they move into far more complex social relationships. And when we're talking, or when we're considering, especially from the mental health side of things, from the three-sided die that we're rolling here, with trauma and drug and alcohol use and mental health, the mental health issues and the symptoms that maybe that were in place beforehand can become more pronounced and more easily observed with the more complex social relationships that start to really take hold during adolescence. So teenagers are just less predictable overall, and that has to do with their experimentation. And there's going to be a really interesting tie-in when we get to the mental health discussion. In a way, some of the percentages for what we can expect to be seen in teenagers, the less predictability has an interesting tie-in with that when we compare them to adults. So, and behaviorally, socially, a lot of times we frame things from an Ericksonian perspective, thinking about there are certain crises at each stage of life, and the more successful we are in resolving that crisis, then the more successful that we, of a base that we lay down to build the next crisis that we face. And so, during this period of life, from an Ericksonian perspective, teenagers are trying to figure out who they are, how they want to behave as adults, relying on the structure and the boundaries that are set around them, and that's in certainly a best case scenario, that parents and caregivers and loved ones around the teenager help set those boundaries so that they can do this kind of experimentation, but in a safer way. A lot of times the higher level need, riskier adolescents that a lot of us wind up working with have not had that routine structure. And then that ties into the complex and developmental trauma impact, and certainly that can lead to anxiety, and then there can be drug and alcohol use from a lot of various factors. So, supporting clinical observations and feedback from the field. This was an interesting, I think it was an editorial from Jaworska and McQueen. Adolescence is a unique period relative to both childhood and adulthood, rather than a linear progression from one to the other. So, reinforcing what I was just saying, and I really like it when really smart people publish stuff that agree with what I say, so that's why that's in here. How does this impact the understanding of adolescent behaviors in differentiating expected from problematic and from impairing? Now, those are interesting lines, and with teenagers, they are difficult ones from a diagnostic perspective to say that this is a risky behavior, but it probably falls in line with normal teenage behavior, maybe at the boundaries of normal teenage behavior, but this is more normal, or this is past the point of being normal, but it's not necessarily impairing, or this has crossed the line into full impairing. So with teenagers, that can be a difficult thing to do, and when we're talking diagnostic assessment and getting information from collateral sources, there can be a lot of different views on where those lines are. And certainly from our clinical perspective, it really relies on where our perspectives are in drawing those conclusions diagnostically. So this is a modified version of ways that we use to conceptualize the complexity of youth that are living with a lot of different areas of risk and need. And in this is not just a representation of these are risky kids. These are just kids. These are kids with a lot going on, and most of what's in this is absolutely expected and normal for kids. And when I say kids, I'm talking about 12 to 20 or ish, in that range, talking about adolescents. So, what's going on in the youth, him or herself? We have physical maturation balanced with sexual maturation, balanced with all of the active brain development that's going on. All of that is going on in every teenager, or at least hopefully. In the teenagers that we are talking about specifically, wrestling with the triumvirate of issues, is that actually a word?
It is now.
It is now. So if you say it out loud, it's actually a word. But what we're considering is kids who are experiencing at some degree mental health, overlapping substance use, overlapping trauma, overlapping mental health, and so on and so on. With all of that going on with the absolutely normal course of other developmental areas. Now, kids, teenagers, do not exist in isolation. And as I mentioned before, they are in a lot of ways expected to make decisions from adult perspectives, which is not fair. But they're also expected to answer like they are still kids. And so there are all these different domains and areas that kids exist in, and we want to consider the back and forth influences of these different domains. And so when we are considering, really you could do this with any teenager, but we use it when we're considering kids with a lot of areas of risk and need, because the complexities are so high and there's so many different areas to consider that we try to help the clinician expand their conceptualization of the different areas that are going on and the influences that they can have. So we consider what's going on from a family domain perspective, from a peer and friend domain perspective, in the school domain, and in the community. For a lot of our high-risk youth, the community perspective includes some sort of legal or juvenile court diversion or deeper level involvement.
You know, and I'm struck, Mike, with maybe another circle that we need, which is kind of this overarching fact that youth have to navigate social media and the anxiety that could produce in many youth. So I think social media, I mean, I think it relates to community and peers, but the reality is it's just a largely significant part of everybody's life and can cause a lot of consternation.
Consternation is that is a good anxiety-related word or term. Yeah, so it is. It's an anxious period of life anyway, just from day to day, probably hour to hour. But the social media availability, I think, can only serve to increase that. And then, you know, that gets into, if we talk about the family domain, is how do you monitor that? So now we can expand anxiety off to the parents and the caregivers as well. Thinking about the three specific intersecting areas within our youth, beyond what is just the normal expected course of jumbled, intersecting, overlapping areas of anxiety-provoking teenagehood, our teenager involving mental health, substance use, and trauma considerations, just some considerations we have from those perspectives. On the mental health side of things, when we're thinking about the intersection of all three of these, and from the experience that we have, Rick and I have at the Center for Innovative Practices here in Cleveland, we do a lot of consideration of co-occurring issues, youth with co-occurring issues, and so we consider very, very directly and specifically mental health as it intersects with drug and alcohol. What that does tend to not acknowledge as directly as it should is the very high commonality of trauma, complex trauma, developmental trauma issues. But when we think about it from the co-occurring perspective, a lot of times the question comes up with clinicians, you know, which came first, chicken and egg kind of question. And ultimately, I don't know that that really matters when we're talking about what's going on symptomatically currently, how can we help this youth and the family be less risky, be safer. But with the finding that half of all lifetime experiences of mental illness start by the age of 14, we find that mental health symptoms, disorders, problems, issues typically arise before drug and alcohol use starts. That's half of all lifetime experiences of mental health disorders, as measured across a person's entire lifespan. Not did you experience it in the last year, but have you ever in your life experienced? Half of them start by the time we are 14 years old. That's a really significant number. And if you think about, and I'm gonna put one foot up on a soapbox for a second, and I promise not to stand up there for too long, but if you think about the attention and the money that is paid clinically and just in the broader health perspective to adults as compared to adolescents, I think we are really, really missing where we should be focusing our research and our money and our efforts, not after the horse is out of the barn, but before the horse gets out of the barn. If we can tackle things during childhood and adolescence, and if we can spend a lot of good clinically addressed time during this period of life, a lot of the later problems can be mitigated. Certainly not erased, but mitigated. So on the other side, on the top there, also in the different shade of purple, the NCS-A is the National Comorbidity Study the Adolescent Supplement, and we're going to refer back to that in just a minute. But nearly 1 of every 3 adolescents meet criteria for an anxiety disorder. That's not they have symptoms of. When they were given assessments from the DSM-4, they crossed the threshold into a diagnosable anxiety disorder, according to the comorbidity study. So, and we're going to talk about what the implications of that are in just a minute. So, directly underneath that, on the substance use side of things, annual marijuana use by all teens rose in 2017, and very, very frighteningly, annual inhalant use by 8th graders rose also during that year. Most drugs of abuse, and that includes nicotine, well, nicotine depending on how you frame it. It includes cigarettes and alcohol. Most drugs of abuse are at the lowest levels in terms of percentage of teenagers using them, the lowest levels that they have been measured in a generation. And that's great news. Unfortunately, marijuana use is increasing, and certainly it has been legitimized state by state, and it's not a dangerous drug. God gave it to us. It grows out of the earth. It's perfectly natural, that sort of thing. These are things that you hear, not just from teenagers, but from adults as well. But certainly when you work with teenagers, you hear these sorts of things. And so there's a very low perception of danger associated with marijuana use. And I don't know. I won't engage in the argument here that that might be true for adults. It might not be that dangerous for adults in terms of occasional recreational use. But during this period of brain development for adolescents, there is no safe level of a recreational psychoactive substance to be used. So there's no safe level of marijuana, intoxicating marijuana, to be used by an adolescent. So that particular drug is increasing in its overall use. It's not at the highest levels ever measured, but if you think about the content of the THC in the marijuana, that's definitely at the highest levels ever measured. So there's kind of a trade-off there. And in terms of overall teenage substance use, the drugs themselves ebb and flow. Teenagers are not right now willing to touch in very large numbers at all. They're not willing to touch anything that's opiate related, and that's understandable. They're hearing what's going on, and unfortunately a lot of them are seeing firsthand. They're being impacted by it, but they're not using it themselves. But that's not to say that those same teenagers are like, oh, okay, well, I'm never going to use drugs. They wind up using something else. So while the percentages of individual drugs themselves go up and down, they go in and out of fashion, the percentage of teenagers using stays pretty steady across generations. So right now the mantle is being carried by, well, particularly marijuana. Vaping is certainly, I mentioned nicotine being very low, but that's as measured in cigarettes. Vaping is increasing in really, really rapid rates, and in a frightening way that I think that we're going to see down the line. So, and then the last one on this slide related to trauma. 1 in 4 children in the U.S. experiences at least one potentially traumatic event before the age of 16. That's coming from the NCTSN. And if you're not familiar with the National Childhood Traumatic Stress Network, I would encourage you to increase your familiarity as a resource for trauma, complex trauma, developmental trauma as it relates to children and teenagers. It is, if you work with teenagers, it's a resource that you should be familiar with. So when we're thinking about these 3 different areas and the way they overlap, and now thinking as somebody who is going to be diagnosing, thinking about the symptom identification and the differential diagnostic overlap, we have 3 separate areas, but there's 4 points of overlap here. We can think about the areas themselves individually, the mental health area, the substance use area, and the trauma area. But then we can think about where trauma overlaps mental health, or where trauma overlaps substance use, and et cetera. So there are a lot of areas of overlap, and I think that this is very specific to teenagers, and my viewpoint is biased, and I am guilty a lot of saying, especially for teenagers when I talk about things, but I think that this is true, and I think I can legitimately say, especially for teenagers, the expression of symptoms in teenagers from one to the next area looks very similar. The expression of experiences from complex trauma looks a lot like what you might see behaviorally from drug and alcohol use and what you might see from multiple areas of mental health issues. Whereas symptoms of ADHD, symptoms of anxiety, symptoms of depression, they can all have very, very similar expressions. In adulthood, we would expect these things to fall into more identifiable, separatable, also a made-up word, categories. But in teenagers, because of what's going on developmentally, a lot of the behavioral and acting out expressions of these disorders just look very much the same. So moving into thinking specifically about anxiety and starting out with a view of overall prevalence. And you know, we referred to this one a couple of minutes ago, the National Comorbidity Study. This was a very large survey. It was conducted back at the, it sounds funny to say this now, but at the turn of the century. I'm definitely feeling old since we're saying that. A survey of randomly selected teenagers, not teenagers that were referred by agency involvement. These were randomly selected teenagers. They were given screening and assessments by trained professionals from a DSM-4 perspective, and they found that the lifetime prevalence of anxiety disorders for teenagers was over 30%. That is crossing the threshold into a diagnosable level. And overall, the National Comorbidity Study, using those same measures, said that 50% of all teenagers, of these randomly selected teenagers, met criteria for at least one diagnosable mental health disorder. So if you have a teenager yourself at home, you know, I think you can jokingly say, and hopefully jokingly say, yeah, I understand that, you know, teenagers are just diagnosable because they're teenagers. But crossing the threshold into actually impaired by a disorder level, luckily half of the teenagers in the U.S. don't cross that threshold. And when they reset that threshold and said, we're going to have to set that threshold saying that the symptoms of these disorders are impairing the functioning of that teenager, then it wound up at about 20% overall. And that makes more sense because when we think about last year prevalence of mental health disorders in the adult population, it's about 1 in 5. So that predicts about where we would be. It's not 50%, it's probably about 20%. But it is interesting thinking about teenagers express symptoms of anxiety to the level that if they were adults, 1 in 3 would be experiencing an anxiety disorder that would cross the threshold into a diagnosable disorder. So, you know, what does this say? It says that this period of life is pretty anxious, and so the symptoms of anxiety are actually kind of a normal experience during your teenage years. At an impairing level, it fell down to about 8%, that teenagers were experiencing anxiety at about 8%. So the comorbidity study measured individually areas of anxiety, including agoraphobia, generalized anxiety disorder, social phobia, specific phobias, panic disorder, PTSD, and separation anxiety. So overall, of all the anxiety disorders, specific phobia was, and it was by far, it stood way out, the most identified anxiety disorder, and that is as identified by overall symptoms. And it's interesting that when they said that you have to cross the threshold to severe impairment, specific phobia actually fell to the bottom of the list. So, you know, to me, this says that phobic anxieties are pretty normal during teenagehood, and they're not necessarily to the level of impairment, but they are a component of being a teenager. On the severe impairment side, I would expect that generalized anxiety disorder would be at the top of the list, but on the severe impairment side, they found that agoraphobia and panic disorders tied for the most identified areas of impairing level of anxiety for teenagers. This is coming from that study, and it is a really nice looking bar graph, so we threw it in here. I'm not going to spend any time on this. So, a quick note about what they included. PTSD is now included in the trauma and stressor-related chapter. It's not in the anxiety chapter anymore, but it does provide a really nice point of overlap for us because certainly we are considering trauma, and one of the components of trauma that we consider, it's a harder threshold to cross in our teenagers, but we are considering PTSD. So they noted overall symptoms were at 5% and the severe impairment was at 1.5%. So. But then coming from the NCTSN, they note that some studies indicate that by the age of 17, over 13% of teenagers at some point during their life have experienced PTSD at some level. So it's pretty significant and it's pretty expected.
Mike and Christopher, I'm curious, when we think about anxiety and we think about internalizing disorders, what has been your experience in terms of co-occurring mood disorders along with anxiety? And I don't know if you have any kind of comments or research on that.
Hi, this is Christopher Belanci. Very high co-occurrence between anxiety and depressive disorders. I think it's a little less clear if we're talking about bipolar disorders or any of the mixed mood states. But there are some folks that actually theorize that anxiety and depression are almost linked inextricably because the comorbidity between the two is that high. And it's fairly common to have pieces of both. Now, sometimes they're alternating in terms of which is kind of the biggest driver. And so some approaches, manualized approaches for cognitive behavioral treatments will allow you to kind of shift the focus of the intervention depending on what's the predominant symptom at any one point in time, and allowing you to focus on what's the most pressing concern both for the adolescent and for their parents.
And from a psychopharmacology standpoint, is the treatment of mood disorders and anxiety disorders similar?
Actually, that's part of why people wonder about the linkage. So the class of medications that would be the most appropriate to treat anxiety in the context of a substance use disorder would typically be the selective serotonergic reuptake inhibitors. So that's the class of medications like Prozac, which is the oldest SSRI on the market, Celexa, Lexapro, or some of the newer ones. They work for both anxiety, and they work for most of the anxiety disorders, so they would include panic disorder, social phobia or other phobic disorders, even obsessive compulsive disorder. A little less clear how effective they are for post-traumatic stress disorder symptoms, but really all of the subtypes of anxiety disorder, the SSRIs work, and they also work for depression. And so it's interesting that you got the same class of medication having an effect on both disorders, which again makes people wonder about the linkage between the two. For this population, you would definitely want to avoid benzodiazepines. So that's the medicines like Ativan, Valium, even Klonopin, for the concern about the impact on the substance use disorder. And they also, the benzodiazepines would not help with the depression. So interestingly, they would only be effective against the panic attack or the anxiety symptoms specifically.
You mentioned, Christopher, you mentioned the obsessive compulsive disorder, which is near and dear to my own heart, and in my family's heart. We've often thought of it as kind of a kissing cousin of anxiety. But in the current, in the DSM-5, it's a separate category, and I didn't know, and you mentioned that some of the same medicines help with OCD as they do with anxiety. I don't know if you wanted to comment on the separation out, or if you see them as strongly related to anxiety.
Yeah, it's an evolving understanding of the underlying mechanisms that drive an obsessive-compulsive disorder. And obsessive-compulsive disorder is fairly neurobiologically driven. So we have better biological models for what's happening in an obsessive-compulsive disorder condition than we have for something such as generalized anxiety or depression. And I think that might have played a hand in the DSM committee deciding to make it its own distinct category, apart from the anxiety disorders. But in terms of treatment, at least psychopharmacological treatment, but also actually psychosocial treatments, the approach is pretty similar. So there's cognitive behavioral approaches that are very effective for obsessive-compulsive disorder, as they are for anxiety and depressive disorders. And the SSRI medication class would also be effective for obsessive-compulsive disorder and anxiety disorders and depressive disorders. So there still seems to be, at least from the treatment end, some association and linkages between the other two disorders.
Thank you very much.
Yeah, thank you. And I'm going to be interested, and I'm going to ask you about this very shortly here, Dr. Balanci, in terms of a lot of the conceptualization is moving towards, when we're talking about these intersecting areas, is moving towards identifying very similar pathways neurologically that lead to certain levels of, or certain types of disorder, and then also being drawn to certain types of substances to abuse. And when we include trauma as a factor in that too, the way maybe some of those particular areas have been increasingly disposed to move in that direction by the way that maybe some neurotransmitters or hormones have been more or less available than they normally would have been. And is there any effect then when we think about from a prescriber point of view, what are the limitations in the thoughts if somebody is using drugs or alcohol while they're also trying to recover from a specific mental health disorder? So, but we'll get to that shortly. I just, if I don't say it now, I'll forget to prime myself for that in a minute. Moving into the DSM-5 consideration, currently what is organized for and around anxiety. There is separation anxiety, mutism, the specific phobias, social anxiety, panic, agoraphobia, and generalized anxiety disorder. On the substance abuse and medication-induced side of things, there are more classes of medications that can induce symptoms of anxiety than any other disorder in the DSM. When it comes to inducing symptoms of presentation of anxiety disorders, either on the use side or on the withdrawal side, during intoxication, during withdrawal, or after medication use. It seems like virtually everything is fair game for consideration. Alcohol, certainly, and that's so similar in some ways, and Dr. Balanci, tell me if I'm wrong here, but it's very, very similar to its neurochemical aspects of the benzodiazepines that you were talking about, and the limitations that you'd want to consider with teenagers and anxiety. Caffeine, which certainly can increase, probably not from a normal consumption level, but we think about the energy drinks that are very popular. I think with just about everybody, but youth really rely on those with their odd sleep hygiene. And then it's also possible to get caffeine powder online, and that's extremely dangerous, and that can have a lot of effects. Marijuana, the cannabinoids have a big impact both during intoxication and then especially during withdrawal. And when we see the external motivators for teenagers, that being either parental crackdown with rights and privileges associated with remaining abstinent from cannabis, or more commonly, at least from the perspectives of the teenagers that we wind up working with, they're being tested by the legal system in some way, and there's some pretty severe consequences on the other side. So they go from pretty regular use of cannabis to really reduced use or even no use. And the withdrawal that we see from cannabis can be pretty significant with teenagers. And on this entire list, it's worth mentioning with teenagers, typically teenagers are bingy users. They are users of opportunity. They don't settle on one particular drug like adults do and rely on it on a daily basis as much, with the exception of marijuana. It's entirely possible to be working with a 15-year-old teenager who has been using marijuana every single day for the last 4 years, and that's very, very uncommon with any other class of drugs. So when we're working with teenagers, cannabis is something that we can see a very pronounced and profound withdrawal side effect with marijuana. So, and that really comes out as anxiety sometimes. So PCP, hallucinogens, inhalants, and we noted that those are increasing among the younger side of our teenagers. Opiates, most definitely, and then there's the sedative hypnotics, and for the most part we would consider that in terms of abused drugs on the benzodiazepine side. Amphetamines, unfortunately amphetamines, specifically methamphetamine, is in a lot of the regions that we are working with, we're seeing a rebound of methamphetamine, and it seems to be taking the place of opiates and narcotics in terms of people are recognizing the dangers, with using the pain medications and heroin, which is not to say that it is going to stop people from using drugs at all. And when that happens, it seems something else fills the void. And we are seeing a spike in methamphetamine. So cocaine. And then on the other category with teenagers, there's a lot of other things that teenagers are willing to use that adults would not. Some of the biological kinds of things, the alkaloids, and we'll touch on those in the substance use side of things. So, but when it comes to the impact of substances and medications, and Dr. Balanci would certainly be the person to talk about the medication side of things. If certain medications can have that anxiety-provoking enhancement, or maybe even masking it until it is stopped or slowed down.
Mike, just on that previous slide, I think it's really so important to think through as we try to figure stuff out. I mean, I think a lot of the times when we're working with a youth and a family, we're problem solving and we're trying to figure stuff out. And I think what we're doing a good job of today is adding to the complexity, which is not necessarily a bad thing. I mean, I think we have to think complexly so that we can best help. But what I really liked about this slide was not only how anxiety and substance abuse could interact, but also the withdrawal from substance abuse using drugs. And thinking about, so withdrawal from a sedative, what's that look like? Taking amphetamines, what does that look like? Withdrawal from amphetamines, what does that look like? And those can be different. And I think part of getting to know the youth a little bit better, helps with that. And so much of our, diving into the diagnostic piece or the problem-solving piece is so much based on our engagement with the youth and the family. What we don't know, we don't know. And in the fact that we have engaged well and are getting good information helps us in best helping the family.
Yeah, and that's a nice preparation for the way that we try to conceptualize these very complex cases. So, and we kind of touched on that with one of the slides, and certainly that's how we will wrap things up, because that overlapping conceptualization and understanding is very, very difficult. So in the DSM, all anxieties include features of excessive fear and anxiety and associated behavioral disturbances. I don't think that it's fair that they introduce the section on anxiety by using anxiety to define anxiety. But they go on to describe fear as an emotional response that is often associated with an autonomic arousal. So here you think about the sympathetic nervous system, that fight or flight reaction to a real or a perceived threat. And then anxiety, differentiated from fear a bit, described as that anticipatory of future threat, often associated with muscle tension and vigilance. And then you think about that description, and then how does that overlap with complex trauma and the things that a lot of, and this is true for adults as much as it is for our teenagers and even the children that we would work with, and this really overlaps into the ACEs study. You think about how do they appear, how do they present with that muscle tension, vigilance, hypervigilance, and then how does that come out, and how is that then interpreted maybe on the mental health side of things? So both of these terms may be described in subjective emotional ways, feelings of fear or anxiety. Both may also describe physiological states that may be sub- or pre-conscious, fight or flight alterations, intentions, things that people certainly are not aware of. There is no direct intentionality in these behaviors, and certainly not beyond even no intentionality. There's no desire for them. But if that's the way that that individual is being wired to both feel and to behave, that's pre-conscious. So rather than a single neural pathway or a fear center, which is the simplified way of thinking about it, this may describe multiple involved brain areas, including, importantly for our developmental consideration, cortical pathways that are undergoing very active maturation. So, what's the presentation and the impact for teens? And I think in this consideration, we were thinking about when we put this together, thinking about the impact of developmental trauma. And I just mentioned the ACEs study. Thinking about those adverse childhood experiences that are very much the developmental trauma inducing and related sort of things. How does this present, how does this appear in teenagers? So the things that lead into developmental traumatic experiences, and so that's not a singular traumatic event. It is an accumulation of these exposures, and for children, these exposures are uncertainty and abuse and neglect, but the uncertainty being the really big piece. How does that then get expressed by teenagers? Because what they've done is they have learned to exist in a certain way, in a protective way, and then how does that get expressed during the teenage years? And so what do you see? And I'd be interested in feedback both from Rick and Christopher on this, and if any of you listening have input on this, with experience in working with teenagers from developmentally complex traumatic backgrounds with overlapping identified mental health concerns, and then what do you see substance use-wise. But thinking about very specifically, how would this get expressed as anxiety in teenagers? I'd be interested in some of that feedback. And then also considering the influences of the complex trauma that I was kind of infusing in that. And then what are the implications for medication if multiple pathways are involved? What happens if all three of these pathways are involved when we're thinking about coordinating with a prescriber? So, and I'm going to pause for a minute and see if not just our two doctors on the line here, a PhD and an MD, so we've got good bookending perspectives, but also to see if any participants have any kind of input on this.
You know, I'm struck, Mike. Oh, go ahead, Christopher.
For me, I think that's the critical question, is the intersectionality of these conditions. And as a prescriber, I need to know what the young person is taking on their own, which could also include herbal supplements and other things that could impact anything that I might want to use, such as an SSRI, to treat the underlying anxiety disorder. You know, there are still agents that can be helpful for instance, alcohol use disorder, like disulfiram. You know, that's going to help with the substance use disorder, even in the context of an anxiety condition, but it's not going to help with the anxiety symptoms. And what I will frequently hear is, I can't begin to address my substance use until I get some help with my anxiety disorder. And so my first approach would be to really have a good trial of a cognitive behavioral therapy, really teach skills, because medications don't teach skills. And particularly in the substance use community, medications are often not welcomed or considered appropriate by any means, even ones that are not going to worsen the substance use condition. So I want to be very sensitive to that in my conversation. Plus, I want to know what else they're taking, because it can impact the metabolism and the uptake of any medication I use. And it's also interesting to me to understand what the preferred medication is, because as you pointed out, you know, I think I wouldn't necessarily frame it as self-medication, but at times young people are choosing medications that do have a pharmacological impact on their underlying anxiety disorders. Sometimes they're making a good choice in terms of something that actually does seem to have some beneficial effect for their anxiety symptoms, not necessarily productive in a long-term way, but it's giving them some relief. And so they're going to be reluctant to let that go if we're not also then giving them either skills through a cognitive behavioral approach or lessening the intensity of those symptoms through a pharmacological approach.
When I, what I was going to add is slightly tangential, but you know, when I think of complex trauma and I think about substance use and I think about anxiety together, for me it would be to help me understand the anxiety better, but also to help with the anxiety. I would have to probably employ, along with the skill building, family interventions that create safety in the family's life, so that I can start to differentiate a little bit around what's anxiety versus not, number one. But for both PTSD and anxiety, safe, when the youth feels safe, that can also be quite therapeutic. And we also know in PTSD treatment that, you know, that's essentially the first step in any treatment, which is create safety. So there's family interventions as well, and I think so. There's individual cognitive and skill building interventions. I think there's some family interventions, and obviously medical interventions as well.
Yeah, thank you both. Yeah, two big considerations that I think about in terms of my conceptualization of youth with all of these different areas involved with. And Dr. Belanza, you mentioned the consideration of, and then also the cautionary consideration of self-medication. You know, most of the drugs of abuse in teenagers are reinforced and motivated because they are euphoric and reinforcing and they feel good. But there is certainly a component of some self-medication with some of the symptoms that we see. And for those of you who work with teenagers, it's likely not uncommon for you to hear, if not for marijuana, then ... I would be angrier, I would be in more trouble, I would put more holes in the wall, I would fight with my mother more, I would, whatever. So I think that there is very much a self-medicating component to it. It's not the only piece of it. It's not that our teenagers are out there trying very desperately and actively to find the right to find the right natural medications so that they are less impaired by their disorders. But
it could be the excuse for their using.
Well, yeah, the excuse, and I think it's also partially a reinforcing excuse in that there is at least a component of truth behind that. So that's a big consideration, and the considerations that you were discussing psychiatrically sound anxiety-provoking all by themselves, Dr. Balanci. There is a lot to balance there in terms of the things that you want to consider. So
I think, relatedly, in terms of, this whole idea of self-medication and how it gets supported, you also have the family viewpoint that, in substance use, one of the things that we talk about is the family messaging around substance use. And if the family messaging is pretty clear that it's not okay and the parents are taking a stance, that generally leads to a reduction in use. If, however, they also find the behaviors are, somewhat better based on them using marijuana, you might not hear the comments from parents about it's not good for you. And so there might be some subtle support for the use by just not talking about it.
Yeah, absolutely. So, and then that was the other piece, that overall larger consideration of the different domains that are around the youth. So, the complexity of understanding the teenagers that we are talking about. The complexities are very, very high. There's so much going on that it is difficult. It's difficult to piece out and to parse out.
Yeah, and it's an interesting point around the legalization of marijuana in so many states and the increasing use of cannabinoid oils. And I've had a number of families come to me where the parents are actually saying, I'd like to use CBD oil for my child's anxiety. I'm more comfortable with that. It feels like it's a natural intervention. And either would you prescribe it or are you okay with my trying this? And the challenge is we really just don't have good data on cannabinoid oil because we haven't been allowed to study it. There's anecdotal sense that maybe there's some anti-anxietal quality, but I worry, particularly in the context of substance use disorder comorbid with the anxiety disorder, to be using an agent that has substance abuse potential, probably not in the cannabinoid oil format, but and kind of what's the messaging on that? Because it's both, what are we doing physiologically, but what are we messaging in terms of the meaning of using a medication or any intervention for the adolescent, and what are they taking away from our actions? Because I think we need to have that open conversation as well.
Yeah, great point. Great point.
That is a good point, and I just saw a report. It's been out for a little bit over a year now, very specific to anxiety and CBD oil. There was a really large meta-analysis of the current state of research, and it's exactly what you were talking about there, Dr. Balanci, that there have been so many limitations on studying anything in the Schedule I status, and anything related to cannabis is in that Schedule I, even if it's non-THC CBD oil. The study was done by the National Academies of, is it Medicine, Science, and Engineering? Does that sound right? I'm pretty sure that's what it is.
Yep.
That's it? Okay. It came out in 2017. I forget the lead author's name, and I apologize. I would recommend it to people listening if you're interested in, I think really the most current broad evaluation of where things are research-wise with cannabinoids. They looked at over 10,000 studies, and then they wound up with 100 proposed conclusions at the end of this. They had 15 experts on it. And very specifically, CBD oil and anxiety were one of the things that they mentioned, and there has been only one randomized controlled trial in terms of the use of CBD and for anxiety, and it showed no results. So, which is not to say that in the long run that it's not. It's just that the one study so far has not led to any positive results. So that's got to be a really sticky area as a prescriber. No pun intended with marijuana bud and sticky, but it's got to be a difficult area having that discussion with, especially with parents who are really actively engaged in trying and they want something that's more on the natural side, maybe a little bit less manufactured kind of feel to it. So, all right. Just quickly covering, and I'm going to go through these quickly so that we've got time for discussion. I want to make sure that we're at about 1 hour now, and I know that that's where my mind starts to wander a little bit. So for those of you still listening and probably updating treatment plans and typing notes, I want to move through this pretty quickly so that we can get to a discussion period. And I really do invite those of you listening to type in questions and comments. Wait till it's over to type in your criticisms, but questions and comments are always welcome. So the two areas that were identified as being problematic, crossing that impairing threshold line for teenagers, the first one was a specific phobia, and then there are the diagnostic criteria: marked fear, anxiety, specific object, situation. Almost always provokes the anxiety. The object of the situation is actively avoided, or it's endured, kind of with that teeth gritted in, enduring. It's out of proportion of what you would expect. The response is persistent, typically lasting longer than 6 months. Otherwise maybe we'd think about adjustment kind of stuff. Causes significant distress or impairment in that individual's life, which really should be the threshold for every single disorder we consider, and not better explained by another disorder. Also, that's kind of the key to what we're talking about, isn't it? Not better explained by another disorder, because there is so much overlapping here. So one predicts the presence of more, that is one phobia predicts that there are going to be more than one phobias present. It's rare to have a single phobia. That's kind of an interesting note from the DSM. The onset is typically during childhood. And who are we talking about? We're talking about kids at the edge of childhood. Symptoms may wax and wane during adolescence, because everything waxes and wanes during adolescence. And phobias are highly comorbid with other disorders. Up to 60% increased suicide risk, and certainly this is very pertinent to us because we are talking about youth who are wrestling with more than just a phobia. We're talking about kids who are living with the symptoms and the pressures coming from more than just the mental health side of things, but also the influence of substance use and traumatic experiences. So certainly that bottom piece, the up to, there's a much higher risk. And then panic disorder. I think that this can be descriptive on the low end of things for a lot of teenagers under normal circumstances. But we're not talking about the low end of things when we're talking about diagnostically, but certainly symptoms of are probably not uncommon. So describe panic attack. Recurrent unexpected panic attacks has to include 4 of 13 symptoms that include palpitations, sweating, trembling, shortness of breath, feelings of choking, chest pain, nausea, dizziness, chills or heat, numbness or tingling, derealization, fear of losing control or going crazy, as they would describe it, and fear of dying. So many of those symptoms also are descriptive of certain types of drugs, and when they're not descriptive of the certain types of the drugs themselves, they are descriptive of withdrawal from certain types of drugs. And how many of those symptoms also describe what's going on with complex developmental trauma experiences. I think that we could overlap all of those, in certain situations. So when it comes to symptom overlap in our understanding, you can see the complexity that's building already. So that's our walk through, and obviously very, very broadly, our consideration just specifically of the anxiety perspective. Now moving through, and I'll move through both of these next two as quickly as I can, the complex or developmental trauma experiences and the substance use experiences. But I don't want to move through it so quickly that we don't consider this. In the DSM-5, on the trauma side of things, we have reactive attachment and disinhibited social engagement. For those of you working with teenagers, the reactive attachment expression in terms of what's the etiology of that? The etiology of that is inconsistent, unpredictable, and neglectful caregiving during the early years of life. And how often do we see that played out in the teenagers that we work with? The DSM, interestingly, says we're not sure what reactive attachment disorder looks like in teenagers, but for those of you who work with teenagers on a regular basis, you know firsthand what reactive attachment disorder looks like, how it's expressed during the teen years. Certainly PTSD is here, and the identification and the expression of very, very specific and diagnostically careful PTSD can be difficult to diagnose accurately in teenagers because so often their symptom expression is different from that's described in the DSM, because that is more based on an adult presentation and expectation. There's acute stress disorder, adjustment disorders that our teenagers kind of bounce through sometimes, and then the other and unspecified category. So children and youth do not always, or perhaps even rarely, display classic PTSD symptoms. The National Child Traumatic Stress Network, the NCTSN, notes that children raised without consistent safety, comfort, and protection may develop protective coping mechanisms that are not helpful when they move into a safe and supportive relationship. And that is such a nice, concise way of saying what we see playing out. They develop protective coping mechanisms that are expressed in ways that just don't make logical sense then when they get into safe and supportive relationships. And it doesn't have to be children who are in adoptive situations. They can be in family situations that were chaotic during their early years that have since stabilized. And then, how do they act when they're in that more stable environment? It doesn't make logical sense from an adult perspective, but when you think about they have earned these pathways the hard way, and they've figured out ways to survive within those very, very unpredictable, neglectful, or abusing situations, that when they're no longer in those situations, the presentations, the way that they act, it doesn't make sense. So it does when you really think about it, but on the surface it doesn't. So we've mentioned ACEs a couple of times. And it's interesting, if you're familiar with them, that Drs. Anda and Folletti have for a long time, since the late 90s, have really promoted and proposed that all health disorders, not just mental health and substance use, or not just the three that we're talking about today, but all health considerations be integrated, because you cannot remove one from the other. They all do have overlap. So they've been proposing this for a really long time. So the ACEs study demonstrated how prevalent childhood victimization, stress, and trauma are. 60% of participants in the original ACEs study reported at least one adverse childhood experience, and over 20 described at least 3 or more. And when you get up into the 3 and 4 range of adverse childhood experiences, then for those of you familiar with it, you know that really starts to predict very unpleasant things moving into young adulthood and adulthood. The NCTSN, in its discussion of complex trauma, attachment relationships, these are areas, and we spent a lot of time on this in our December presentation, thinking about these areas of overlap symptomologically, behaviorally, problematically, and the way that they play out. So, the attachment side of things, what do you see there? And I'm not going to go through these because I do want to make sure that we have enough time for you guys to participate with your questions and your comments. Physical side, the brain and body sort of things, the extreme reactions, shutting down, physical complaints, risky behaviors, which are descriptive of teenagers anyway, but now we're crossing a line into truly risky behaviors, body dysregulation, things that really start to overlap with a lot of other areas and that can be, I don't know if misdiagnosed is the right way to say it, but, well, there's probably no better way to say it. They can be understood as being ideologically related to something else. So, emotional responses, identifying, expressing, managing emotions. Teenagers are just learning to do this anyway. This is what they're supposed to be learning to do. And then when it is disrupted from a history of learning different ways to survive and adapt, then it doesn't always play out to the best way that it can once stabilization has been achieved. So internalized, externalized stress, anxiety, anger, reactive, lacking skills to calm down, and that would certainly be from that double-sided coin of depression and anxiety and irritation. So many things are expressed through irritation for teenagers. They can be tuned out, and then we can talk about the overlap with drugs and alcohol there. Give up quickly, low frustration tolerance, and when all of these things all just wrap up together and snowball in really, really limiting ways. So the dissociation side of things, and then that really gets into some self-medication kind of considerations with certain types of drugs. If you're familiar with dextromethorphan, which would be Robitussin, Coricidin, things like that, where kids with a lot of complex trauma in their background seem to be drawn to those particular types of substances because dissociating is more comfortable than not dissociating. Lastly, in this, some of the considerations of behaviors, easily triggered, self-regulation again, a greater likelihood of engaging in illegal activities, reasoning and problem solving from the cognitive side of things. Teenagers are already moving from thinking in terms of things in very, very black and white concrete ways into more planful sorts of ways, but if you're limited in your ability to do that based on your early experiences, and then what do drugs and alcohol do to that as well. So sustaining attention, so many of the youth that we work with that get referred to us in our very specific co-occurring programs come to us with a long history of diagnoses of ADHD and ODD, and I don't know how on-target accurate those are. Perhaps they can better be explained by thinking about these sorts of influences. So, then moving into substance use. There's 3 really great surveys out there in terms of prevalence of substance use with teenagers. My personal favorite of the 3 is Monitoring the Future, but they're all 3 very, very good. The National Survey on Drug Use and Health takes a look at not just drug use, but also overall health and specifically depressive disorders. And then there's another one, the Youth Risk Behavior Surveillance. That one comes from the CDC, and that looks at risky behaviors in addition to beyond just drug and alcohol use. So those are the 3 good ones: Monitoring the Future, National Survey on Drug Use and Health, and the Youth Risk Behavior Surveillance. Lifetime prevalence coming from Monitoring the Future in terms of, this is very specific to drug use. 14% of teens report having tried or used drugs other than alcohol, tobacco, or cannabis. That's lifetime. Almost 30% of all teens have used marijuana by the time they graduate high school. It's 1 in 3. 26% of teens have been drunk at least once. Alcohol is at the lowest level that has been measured in the last 35 years. So alcohol use is lower. I don't want to say low. It's lower than it has been in the past. And the alcohol concentration is not getting stronger, unlike the THC concentration. So fewer teens are drinking and binge drinking, but by the time they graduate from high school, a quarter of them have been drunk at least once. So that's still a pretty significant influence. And look at this last one. By 12th grade, 28% have vaped at least once. So while cigarette smoking is going down, and that's fantastic from a public health standpoint, vaping is changing the perceptions of dangers around behaviors that can probably lead right back into smoking. So, on the household survey, in the last year, a little over 4% of all teens suffered from an identifiable substance use disorder, and about 1.5% of all teens experienced co-occurring major depressive disorder and substance use. And that's looking just specifically at a major depressive episode, not taking a look at all the other potential overlapping and co-occurring mental health conditions with substance use. I'm not going to cover the prevalence on these specific drugs, but in terms of our consideration of all of the overlapping symptoms to be considered, with alcohol, we think about probably more the withdrawal side of things and the way teenagers use. Most teenagers, and there's always exceptions to this, and those of you listening may have some exceptions that you have worked with. Most teenagers are not daily drinkers, but they are dangerous binge drinkers. And in my experience, they under-identify the amount of alcohol that they are using in bingy ways. So more than anything, we see some short-term withdrawal impact of alcohol. So, those presentations are shaky, edgy, irritability, like teenagers need help being more irritable. With marijuana, we can see very, very heavy active use and some of the symptomological overlap there in terms of trouble concentrating and maintaining focus. But then on withdrawal side of things, if there is a drug, we'll see significant withdrawal impact. It would be with cannabis. And, the sleep difficulties, anxiety, jitteriness, increased irritability, amphetamines, and the stronger the amphetamine, the bigger the impact. Increased energy up to being shaky, and it has the sympathomimetic, that is the sympathetic nervous system, that fight or flight. It can stimulate that, and it can take a look. It looks like some different levels of disorders, and then in withdrawal, it goes in the opposite direction. Tranquilizers, here in our experience, teenagers abusing tranquilizers, it has always been on the benzodiazepine side of things, and the teenagers that we have worked with really seem drawn to Xanax, and even more specifically the bars of Xanax, and that's just, they seem to have an unfortunate level of knowledge about that specific medication. So in use, they can look drunk, but in withdrawal is where you'll see it if they're using it in a bingy sort of way, and especially if it's overlapped at all with alcohol, then it becomes very, very dangerous. So,
I'm curious, do you think kids who have anxiety disorders are more likely to use Xanax as a drug of choice? My worry being that my understanding of Xanax is that it's so highly addicting that it's one of the hardest drugs to come off, to not use after you've used it for a period of time.
Yes, that's true in my clinical experience as well. And again, that's one of the reasons I ask about what substances the young person particularly chooses, and also how that substance impacts them, because it can give me a little window into what underlying comorbidities exist if they hadn't previously been identified. So what is it that they like about it? What's reinforcing about taking that particular medication or substance use? Because again, it can kind of inform the complexity of what we're dealing with. But yeah, I would not recommend Xanax for somebody with comorbid substance use disorder or anxiety disorder. And in general, I avoid the benzos for anxiety disorders in young people who who don't have substance use disorders because of the stickiness of trying to get them off of it eventually after they've learned some CBT-based skills for managing their anxiety.
Thank you. Yeah, thank you. Speaking there, directly to the dependency likelihood with that class of medication. So, and I really like the conceptualization of that window of insight in terms of what draws you to that, and I think that ties back into our consideration that there can be very similar neural pathways for all of the overlapping areas that we are considering. Yeah, we're not going over this.
I have some questions I'm just curious about, or some comments, and just kind of want some people's reactions. For me, anxiety disorder, the term anxiety has become ubiquitous in terms of, I think of my own kids, and they talk about, well, everybody seems to have an anxiety disorder, and thinking, well, no, but we use the term so much that it diminishes the severity when it does exist in a way that affects functioning. So in that, 20 to 30% of youth and or adults who have a true anxiety disorder, it can be very debilitating. And I guess what I wanted to get to is both the social media use of the words, of psychiatric words, terminology, and also the real impact of anxiety, because I think we think of anxiety as like, okay, that's low-level mental health stuff, Talk to me about major depression. Talk to me about bipolar disorder. So I'm just curious if others have experienced that kind of feeling about just the term anxiety. We wanted to talk about it very specifically because we think it's a major driver for co-occurring disorders, but didn't know if that was your experience as well.
And I will mention, with our bit of a pause here, we skipped ahead on the slides, just a few, and really it was just wrapping up the DSM perspective of substance use disorders, which really we did cover in the December one. And even if you weren't on that one, it was just the DSM-5 coverage of some of the overlapping general symptoms of drug use and abuse, although we don't use the term abuse anymore, but thinking in those terms. Moving ahead then into exactly what Rick was talking about in terms of those overlapping areas, and then even a little bit more broadly in the way we have talked about it in smaller threads throughout. We introduced it in the beginning with all of these overlapping areas. This would be true for anybody that we're working with, but with youth we have the extra layers of consideration in terms of what's going on for teenagers just in general, under normal circumstances. And so one of the ways that we use to conceptualize and to help conceptualize and encourage conceptualization of all of these complex interactive areas that overlap, and they all look very similar, and they are so difficult to flesh out individually. But it is important to flesh out individually, beyond just, we want to tackle the symptoms, but understanding the etiological components of it, because the longer term treatment match is important, that we understand and help the youth and help the youth's family understand more specifically what's going on than perhaps they've had before. So I am going to encourage Rick to comment on this, because he has done this type of functional analysis for quite a long time, and even regardless of his obvious outward youth. And also encourage any of you who are still tuned in, logged on, yes, but tuned in, for comments and observations from your own experiences in program development.
You know, I have, as we have somebody typing in, I have one comment around anxiety, which is, you know, so many of the youth that we serve get identified by somebody as being problematic. With anxiety disorders, kids are kind of quiet about it and very private about it for the most part. So I think it behooves us to be good observers and to recognize that, you know, with internalizing disorders overall, but also specifically anxiety, is these, you know, these kinds of kids we're going to have to reach out to help them feel comfortable enough talking about what's going on inside of them, which they might not understand. And, you know, relatedly, you know, doing some psychoeducation with the parents around that. We have somebody typing in, and I'll just wait a second to see if we can see what the question is or comment. So Heather, thank you for chiming in. In working with youth with substance use disorders who are trying to avoid emotional pain, it is difficult to draw from them what they are experiencing, so that relationship between provider has been important. Absolutely. You know, I think, again, when we think about treatment for youth, number one, you can't separate it from the youth and the family, number one, and you can't do the work without a strong relationship with the youth, with the parents. And you really, the end point for me is always, did I help the parent and the youth develop a strong relationship so that they can talk with each other about what's bothering the youth, and so that the family can support the youth, not only in talking about it, but to also deal with it. So yeah, it's very difficult. Engagement is absolutely critical, but both for the youth and for the adults that we work with. Thank you for that comment, Heather. It looks like we're winding down. We have time for one more question or comment. And if we don't get one, we're just going to thank you very much for attending and being with us. We will be doing these quarterly in terms of picking different diagnoses to talk about. We did mood disorders, I think, the first time. And I believe we'll be doing externalizing disorders coming up.
I think that is the next one, yeah.
And so, and as you have comments or questions for us as we want to start to take a deeper dive into this, please let us know. We'll be available, and here's our contact information.
Yeah, and so for the contact information, we left Dr. Belanci's contact information off of there because he is busier than both Rick and I combined. But Rick is also quite busy. So if you have questions or comments, I invite you to send it to me. That's michaelfox2@case.edu. And then I can pass any questions or needs on from there. So I would encourage you to send questions or comments to me. Complaints, send to Rick. And criticism, send to Rick. But any questions that you would want more information on or recommendations, you can filter those through me, and I will definitely get those to Rick and to Christopher.
Our next learning community is on May 23rd, and it's on externalizing disorders and substance use.
And trauma.
And trauma. And August 22nd, we'll be doing ADHD, trauma, and psychoactive substances. So those are the ones we have in the pipeline, and we welcome your feedback in terms of adding others.
Do we have a time on the 23rd, Rick?
We are going to try to do a time that is later in the day so that we can be more inclusive of the West Coast. So we will be working on that.
And really, Rick saying we will be working on that means that Mike should have submitted that request probably a month ago. So I'll do that.
All righty. All right, guys, thanks very much for joining us, and we look forward to talking with you next time.
Thank you very much, everybody. I hope you all have a good end of the week.